So my name is Raymond Osarogiagbon. I am a thoracic medical oncologist at the Baptist Memorial Healthcare Corporation's Baptist Cancer Center in Memphis, Tennessee, where I'm also the chief scientist for the healthcare system. As a lung cancer specialist who practices in the region of the United States where I am in, which happens to be at the heart of the lung cancer mortality belt of America, the idea of finding lung cancer early enough to intervene is very compelling. So in 2011, when the results of the National Lung Screening Trial were announced with resounding success, we were all very excited. We knew it was something which was going to come, and we also knew we didn't know how to do it because we had not taken part in the lung cancer screening trial. So what we did as a pragmatic approach was we decided we needed a practice. And the place we could start from were people who had scans taken that showed an abnormality, and just trying to teach ourselves how to apply existing guidelines to provide care for them. So we started what we call our incidental lung nodule program. And then in 2015, the Medicare coverage decision came about that made lung cancer screening a covered healthcare benefit in the United States. So it turned out the same year we started our incidental nodule program, we also started our lung cancer screening program. And what we did was we followed all patients in the healthcare system who were enrolled into those programs longitudinally with very careful data collection. And what we have found is that, yes, indeed, just like the National Lung Screening Trial said, lung cancer screening saves lives. You can find lung cancer at a much earlier stage, and you're able to do more for people, and you're able to see people survive. What has been a real surprise is the impact of the incidental nodule program approach that gives us about anywhere from 3 to 4 patients diagnosed with lung cancer for every one person we find through the screening program. And the stage distribution of the two groups is approximately similar, not exactly the same. What we have also found is that the rate of diagnosis of lung cancer in our real-world population is significantly higher than what was reported in the National Lung Screening Trial. And that's a little bit of a head-scratcher to try to understand what's going on. Now, this is very important. It's very important because all our projections of the risks and benefits of lung cancer screening, the cost effectiveness of lung cancer screening, are based on the National Lung Screening Trial data. Now, the patients who were enrolled in the National Lung Screening Trial, as usually is the case, are so-called healthy volunteers. They tend to be healthier. Yes, they met your eligibility criteria, but they tend to be people who are more likely to take health-preserving measures. For example, the demographic makeup of the National Lung Screening Trial is not fully representative of the kinds of people who get lung cancer in America. So the National Lung Screening Trial had anywhere from 4 to 5% of people enrolled who were African American, whereas it's about 12 to 14% of lung cancer patients in America who are black. And one of the things that we're learning is that lung cancer screening is even more effective in black people and in women than it is in white males who were the predominant people enrolled in the National Lung Screening Trial. So there are all these reasons for which it was important to look at a real-world population and ask the question, are we helping or hurting, or are we just coasting along as we try to implement lung cancer screening? And the news that we have is that screening, certainly in the population we looked at, in the high incidence mortality belt, is even more effective at least twice as effective, maybe up to 4 times as effective as was reported in the National Lung Screening Trial. So when we start these debates about the safety of screening, the effectiveness of screening, the cost effectiveness of screening, how many lives do we save, how much will it cost us, we feel it's important to get the message out that even in a community healthcare system, lung cancer screening can be done effectively, safely, and guess what? The yield is actually greater than what was predicted.